Hey everybody. Hey guys, I am going to go through these questions through a recorded PowerPoint for you guys who weren't able to be here in a little bit more of a clear way so that everybody kind of has a um, chance to go through this with me as though you're here, since the Zoom recording was more of like a question and answer kind of thing. So I'll go through this quickly. It's going to be a little bit faster than our Zoom meeting too. There are 17 questions, and our first question here is, a nurse knows that a decrease in the GFR is reflected by which laboratory finding? The answer here is going to be B. The reason that it's B is because the creatinine is the creatinine rises when the GFR falls because the kidneys are not being perfused. It reflects reduced renal clearance and a declining kidney function. BUN can increase for many reasons, doesn't necessarily have to do with the filtration of the kidneys, and urine specific gravity varies with hydration. Sodium levels are hormonally regulated, so it's not an indicator of GFR. Question number 2 is, a nurse assesses a client with acute glomerular nephritis. Which finding does the nurse expect? The answer is going to be C, facial edema. The reason this is because glomerulonephritis causes inflammation of the glomeruli, which is a prerenal structure. This is going to lead to decreased filtration, sodium and water retention, and protein loss in the urine. This results in a backup of fluids and peripheral edema. Hypotension and dry mucous membranes suggest fluid deficit, not an excess. So we're not looking at too much fluid in hypotension and dry mucous membranes. We're looking at as volume down, and urine is concentrated in glomerular nephritis. It's not dilute. The urine specific gravity will increase with concentration and decrease when it's dilute. A nurse is preparing discharge instructions for a client recovering from acute glomerular nephritis. Which statement indicates the need for further teaching? So we're looking for the answer here that shows that the patient does not understand his discharge instructions. The answer here is that they will stay in bed for another week. We do not want anybody to waste away in bed. If they are recovering and they're being discharged, we want them up and out of bed as much as possible. Because glomerulonephritis can cause edema, that will require them to weigh themselves daily. They should limit salt in their diet because with salt comes fluid, and they do want to continue to test their urine. A nurse knows nephrotic syndrome differs from glomerulonephritis primarily because nephrotic syndrome causes which of the following? The answer here is B, severe proteinuria. Decreased cholesterol, dehydration, and hematuria are the incorrect answers because nephrotic syndrome is characterized by massive protein loss, leading to hypoalbuminemia, edema, and hyperlipidemia, meaning that the cholesterol levels are going to increase. Hematuria is more so a issue from inflammation, and fluid shifts cause edema rather than dehydration. All right. Question 5. A nurse assesses a client with nephrotic syndrome. Which complication is the nurse most concerned about? The answer here for nephrotic syndrome is going to be blood clots. The loss of protein in the nephrotic system is going to include the loss of anticoagulation proteins, which is going to increase the risk of extra clotting, and because of that thromboembolism. So this is going to make clot formation a major concern. Hypotension, hypoglycemia, and metabolic acidosis or alkalosis are not hallmark signs of nephrotic syndrome. A nurse asks a client with urinary tract infection which symptoms they are experiencing. Which response supports the diagnosis? Polyuria and urgency, bradycardia, weight gain, or frothy urine? The answer to this one is going to be A, polyuria and urgency. This is because of the inflammation of the bladder and the urethra. You can also see they might complain of burning and frequency also. Bradycardia and weight gain are unrelated. And frothy urine, while it could be mistaken for kind of like a sedimenty urine, typically is more of a suggestion for proteinuria, not necessarily infection. The nurse knows pyelonephritis differs from cystitis because pyelonephritis includes which finding? So remember, pyelonephritis is a upper kidney infection involving the kidney, and cystitis is just localized to the bladder. So knowing that the answer is going to be B, fever and chills, because the pyelonephritis includes the kidney, you're going to see more systemic symptoms like the fever and chills, flank pain, malaise, might even be teetering into more of like sepsis look, like tachycardia, hypotension. Cystitis causes localized urinary symptoms like that like frequency, the burning, the discomfort, the abdominal pain, without the system illness. A nurse assessed a kidney transplant client. Which finding most strongly suggests organ rejection? The answer here is going to be fever and hypertension. Signs of kidney transplant rejection usually include the fever, hypertension, pain over the graft site, decreased urinary output, and things like increased urine output and weight loss are not expected. Actually quite the opposite. We're gonna see with the kidneys that are not working, decreased urine output and weight gain because they're not pushing the fluid out. Bradycardia would be unrelated. Someone had asked, is fever always a sign of rejection in transplant patients? And while the answer is it could be, it's not always, because of the number of anti-rejection medications and immunosuppressants that they're on in order to prevent the rejection. It could also be an infection of another source. So that's why these kind of patients are very immunocompromised. So you got to really get down to, where exactly this fever is coming from. And if it's paired with hypertension and decreased urine output and some kidney malfunction, we're gonna have to kind of err on the side of this might be a rejection. A nurse reviews medications for a client with pre-renal acute kidney injury. Which medication contributes to decreased renal perfusion? The answer here is going to be A. ACE inhibitors act on the arterioles leading in, the arterioles meaning the blood arteries that go into the kidneys. So ACE inhibitors are going to affect the intraglomerular pressure, meaning how much blood is in the glomerulus, and whether or not if that's too little, then the kidney itself won't be perfused. If it's too much, then the kidney's going to have too much stress on it. So with pre-renal failure, if you take ACE inhibitor that also acts on the pre-renal arterioles, you're going to be decreasing that perfusion too much, causing some further like intraglomerular damage. Loop diuretics contribute to volume loss, but don't directly alter the perfusion of the kidneys. The diuretics act in a different part of the kidney and waste fluid a different way. Insulin and calcium acetate, while they are likely being taken by people with kidney issues, this doesn't contribute to the renal perfusion. A nurse assesses a client with acute renal failure. Which assessment finding is most concerning? Um, this one can be tricky because all of these numbers are off. Um, but we're looking for the most concerning one, which is going to be B, potassium of 6.2. Hyperkalemia is of this the most life-threatening complication because it runs the risk of fatal arrhythmias. Elevated BUN and creatinine indicate renal impairment, but are not immediately fatal, and anemia develops chronically. So while these are all incorrect, the BUN and creatinine are kind of expected in renal failure, right? We know that their kidneys aren't functioning properly, but the potassium and the hemoglobin 10.8, that's fine. We don't transfuse until it's under 7. But the potassium of 6.2 can be fatal. A nurse is monitoring a patient in the oliguric phase of acute renal failure. Which finding does the nurse expect? You have to know what oliguric means, which is a markedly reduced amount of urine output. So with that knowledge, then what we're going to expect here, because we're putting out less fluid, we are going to be backing that fluid up into the rest of the body. So the answer is going to be B, fluid overload. Increased urine output and dehydration are that is something that happens, but down the line in renal failure, acute renal failure, and potassium is going to rise. It's not going to fall because the kidneys don't pass the potassium through. So a buildup is going to cause a hyperkalemia, not a hypo. A nurse knows dialysis is indicated when which condition is present. Again, this one's a little tricky because both A, B, and C and D all are all conditions that we don't want, right? But with people in chronic kidney failure, a BUN of 48 and a creatinine clearance of 20 is expected and is could be on the lower end of the values that you're going to see for BUN and creatinine for someone in advanced chronic kidney disease. The mild metabolic acidosis, that's not going to cause alone for someone to be put on dialysis. What is, though, is going to be C, and it's going to be hyperkalemia with the EKG changes because that, again, is life-threatening. That alone, if we can't find a way to get the hyperkalemia down consistently, we're running the risk of this patient having, some significant cardiac events down the line. So again, while these are all abnormal, C is going to be the one that we're looking for. In the review, someone had said that you in your guys' notes, I think, a BUN of greater than like 120, I think, was the indication for dialysis. So with these questions here, hyperkalemia is gonna be one of those indicators. A nurse caring for a client receiving peritoneal dialysis notes cloudy dialysate return. What is the nurse's priority action? The answer for this one is going to be C. We're going to always be assessing for infection. We're eventually going to document the findings. We're going to only continue the dialysis if they're not in any like acute distress. And we're not going to change the dwell time because it can worsen the infection, and that's not necessarily our call as nurses. So the answer here is going to be assess for infection. We're going to look at the site. We're going to ask if they have any peritoneal discomfort. We're going to look at the vital signs, ask how they're feeling. So infection, that's what we're looking for here. A nurse knows which action is appropriate when peritoneal dialysate is not draining. the answer for this is going to be B. We're going to reposition the client because of the placement of all the ports and body, habitus and what have you. Moving them around is going to be the best way to kind of figure out if that's what the issue is. We're not going to advance the catheter or irrigate the catheter because that's going to kind of break the cleanness or the sterility of it. And we're not going to stop the dialysis unless that's ordered, unless we can't get it going again. Question 15. A nurse assesses a client after hemodialysis, which finding requires immediate intervention. Of these four, the one that sticks out is going to be B. The other three are expected, right? Mild fatigue. This usually happens at 5 o'clock in the morning, and they just took all of the fluid out and put it back in. Decreased BUN means it's working. And dry skin is just something that's a kind of very common in dialysis patients. So the hypotension and dizziness is something that we want to treat right away so that it doesn't cause further systemic issues down the road. We want to make sure the blood pressure is high enough to continue perfusing all of the organs that are that need it, right? The brain, the lungs, the heart, and what's left of the kidneys. So the answer here is going to be B, hypotension and dizziness, or any symptoms that might indicate hypotension, severe tachycardia, dizziness, lethargy, profound lethargy, weakness, altered mental status. Those are the kind of things we're looking for. The nurse assesses a client with chronic kidney disease, which findings are expected. This is a select all that apply, and the answers for this one are going to be A, B, and C. Anemia is expected because of the decreased erythropoietin. B is hyperkalemia. We've talked about that. The excretion of it is impaired because of the decreased renal function. And the metabolic acidosis is typical, and it's because of the reduced buffering ability. And D is incorrect because you're actually going to see increased phosphorus with CKD because it's one of those bigger molecules that has a difficult time passing through impaired kidneys. So you're going to see that's wrong because you're going to be seeing high phosphorus, and that comes along with that, you're going to be seeing low calcium because they work inadvertently with each other. And the last question here is a nurse providing teaching to a client with an AV fistula, which instructions are appropriate. Select all that apply. The answers here are going to be the ones that they're being the most careful with the AV fistula because they are fragile and they are a lifeline, and they're difficult to maintain, they're difficult to create. So the answers are going to be A, B, and D. The reason that C is wrong is because tight clothing, similar to a blood pressure cuff, can restrict blood flow. And we want to keep that very well perfused. We want to make sure that thrill and the bruit are happening. We want to make sure the thrill is happening, the bruit is not happening, and that the blood pressure cuff is not touching it because, again, we want to keep that fully perfused. All right. So that is all the questions that we went over during the review. This was just in a very rapid, fast pace. I'm going to post the slideshow and this so that you guys can kind of look at it separately. And please, by all means, reach out to me with any other questions. I'll be happy to help however I can. And good luck on your exam.